we will cover now. All you need to know is the names of the criteria, okay, of these ectopic pregnancies. Ovarian ectopic, the criteria is Spiegelberg's criteria, okay, and so don't remember the criteria, that's not important, just the names are enough to remember. Abdominal ectopic, Study Ford criteria. Okay, cervical ectopic is Rubin's criteria. So again, I'll repeat, ovarian is Spiegelberg's, abdominal is Study Ford, cervical ectopic means the pregnancy is in the cervix. If you look at this ultrasound, this part is the cervix, okay, and here is the uterus. So the pregnancy is in the cervical canal. So Rubin's criteria. This is one of the recent, I'm not recent, but more um, commonly seen ectopic pregnancy these days compared to previously is a cesarean scar ectopic. So you can see this is a laparotomy picture where the pregnancy has gone inside the cesarean scar, and this can lead to a rupture on the outer surface. So this is how it looks like on ultrasound. It is neither in the cervix nor in the endometrial cavity. It's right at the isthmic region, that is the lower uterine segment. Now, one hypothesis is that suppose this pregnancy grew without rupturing, what can it end up being? What can this become if it grows without rupturing? We discussed this yesterday. Very good, Naman. It is one hypothesis of placenta accrete syndromes, not abruption. Placenta accreta. One of the hypotheses is that its origin lies in a cesarean scar pregnancy. So, cesarean scar pregnancy, if it grows without rupturing, it becomes placenta accreta. A pregnancy which is growing in a cornua of a Mullerian anomaly. So it's called a cornual pregnancy. This is a bicornuate uterus. So the pregnancy in one horn of a bicornuate uterus is called a cornual pregnancy. Okay. And lastly, heterotopic pregnancy. What is heterotopic pregnancy? Heterotopic pregnancy is something which used to be very, very, very rare. But now it's seen more commonly. Why? Because of IVF. What happens in heterotopic? One pregnancy is intrauterine and one is an ectopic pregnancy. Okay. Now, what is important to understand as is that how will you manage a heterotopic pregnancy? So you have one pregnancy here and one pregnancy intrauterine. Study Ford is for abdominal pregnancy. That's all you need to remember. Tanush, I won't go into the criteria mein kya aata hai. Just remember abdominal. Also remember Study Ford is for primary abdominal pregnancy. I'll just come to that. Let me just complete this first. So intrauterine and ectopic pregnancy. Now, if the intrauterine pregnancy is a viable pregnancy, that means if it is a live fetus and the mother wants to pregnancy, then what should she do? What is the best option for her? It is not methotrexate, it is only and only a surgical management. Because if you give methotrexate, it's going to kill the intrauterine pregnancy also. So in a heterotopic pregnancy where the intrauterine pregnancy is viable, what is the treatment? The treatment is surgical because methotrexate is going to be contraindicated. If you give methotrexate, it's going to affect both the fetuses. It's going to kill off both the intrauterine and the extrauterine pregnancy. Now coming back to Dhanush was asking abdominal pregnancy ka criteria. Okay, surgical means your this one is जो भी हमने अभी पढ़ा, if it's an unruptured ectopic, salpingostomy or salpingectomy. You can't allow medical management in a heterotopic pregnancy. So Study Ford criteria जो है ना, this is for a primary abdominal pregnancy. What do you mean by primary and secondary abdominal? How does abdominal pregnancy form? Abdominal pregnancy forms either the pregnancy itself formed in the abdomen. That means the fertilization happened in the abdomen. Or the other situation is that the pregnancy formed in the tube, then it got expelled into the abdomen and then started growing. So, study Ford criteria is for the primary abdominal. This is a secondary abdominal. It doesn't really make a difference कि कहाँ से आया कैसे आया, but study Ford described the criteria for a primary abdominal pregnancy. Okay, so this is the different types of ectopic pregnancy. And now we go to questions. But before that, I compiled some important things to solve questions. Remember, ruptured ectopic pregnancy is a clinical diagnosis. Okay, surgical management is the rule. There is no role of doing beta HCG in a ruptured ectopic pregnancy. Third point, beta HCG is important in determining number one, management of a pregnancy of unknown location, and also determining the mode of management in an unruptured ectopic. That means whether you're giving expectant, medical or surgical. इसके लिए भी we should know the level of beta HCG. If it's less than 1000 expectant, less than 5000 medical, more than 5000 surgical. You should know what is doubling time, what is discriminatory zone, and remember the criteria for expectant, medical, and surgical management. So once you've understood these concepts, you should be able to answer all these questions. A 23-year-old woman comes to the OPD with amenorrhea of 5 weeks. Her UPT is positive. A TVS is done which shows normal uterus and adnexa. What do you mean by adnexa? Adnexa का मतलब क्या है? What is the exact meaning of adnexa? Adnexa means those structures which lie between the uterus and the lateral pelvic wall. So what structures lie between the uterus and the lateral pelvic wall? The fallopian tube, the ovary, and all the supports, the ligaments, like the broad ligament of the uterus. So these constitute the adnexa. Okay, so I'm just telling you, if you encounter this word, you should know what it means. Yes, the answer is do a beta HCG and doubling. TVS after 1 week, if you do, somebody wrote this, Swapnil wrote this, repeat TVS after week. Yes, you could do this, but if it was an ectopic pregnancy and this ruptures, it will end up in a catastrophic event. So the patient will come back in shock. So you want to be safe. So do a beta HCG, repeat after 48 hours. If it's doubling, then you can sleep well at night. Okay, a 34-year-old lady with a history of a tubal sterilization is diagnosed to have an unruptured ectopic pregnancy of size 4 centimeters. Serum beta HCG is 6000. The preferred management option is what? So she's fulfilling the criteria of surgical management. Yes, because of the size, because of the beta HCG, and she has undergone a tubal sterilization surgery earlier. So what do you want to do amongst the two? You want to do a laparoscopic salpingectomy, remove the tube. Uski family to complete hai na. She's undergone sterilization. Don't leave the tube behind. A 28-year-old woman with a history of infertility for 3 years presents with 6 weeks amenorrhea. She has mild pain and spotting. Her UPT is weakly positive. On examination, she is stable. There is a 3 by 2.5 centimeter left-sided adnexal lesion. Beta HCG is 2500. Ultrasound reveals a left side sac with no cardiac activity. So she is fulfilling everything for medical management. So she is going to be given injection methotrexate. मैंने बताया, I answered that question before, bacha. 31-year-old presented to the emergency with generalized abdominal pain and vaginal spotting. Her LMP was about 2 months earlier. On examination, she is pale. Her pulse is 120. Blood pressure is 90 by 60. So she's basically in shock. She has guarding and rigidity. UPT is faintly positive. She's in shock. Okay, no matter how urgent you get the ultrasound or how urgent you do the beta HCG, it's still going to take time. You have to shift this patient to the OT for an emergency laparotomy. This is a ruptured ectopic, so you have to take her to the OT. Okay, which is not a risk factor for an ectopic pregnancy. Tubal ligation is a risk factor. Intrauterine death is POPs. Condom is not a risk factor for an ectopic pregnancy. The classic triad of features in an ectopic pregnancy is bleeding, pain, and delayed periods. Correct. A 21-year-old, 27-year-old G1 with delayed periods, she complains of mild pain on examination. Abdomen is soft. An examination reveals cervical motion tenderness. So this is another feature of ectopic pregnancy. I didn't mention this earlier, but cervical motion tenderness. That means when you do a PV and you move the cervix, this is also, and the patient has having pain, this is a sign of ectopic. It is also seen in one more condition, that is pelvic inflammatory disease. Cervical motion tenderness is seen in PID and in ectopic pregnancy. This is the ring of fire appearance. This is an unruptured ectopic. Why is it not a corpus luteal cyst here? Because there is cervical motion tenderness. This is one clue. And secondly, she has delayed periods. That means she is likely to be pregnant. This is the other clue. Although you can see a corpus luteal cyst in pregnancy also. So the better clue here is cervical motion tenderness. Next question. The most common site for an ectopic pregnancy is शिवम, because fallopian tubes are in the page. अभी मैंने जो आपको laparoscopic picture दिखाया, the surgery I did, didn't you understand? The bleeding, the tube has ruptured, so it's going to collect behind the uterus, right? This is C. C is the ampulla. Okay, C is the, sorry, B is, C is the ampulla, na? A is the interstitial part of the tube. B is the isthmus, the narrowest portion of the tube. Isthmus is also the site where we do what? Where we do the Pomeroy's method of tubal ligation. And this came in this year's NEET PG question, that why do we do a ligation at the isthmus? We do a ligation at the isthmus because it's the narrowest portion. तो अगर हमने यहाँ पे और यहाँ पे ट्यूब निकाल दिया है, ठीक है, and this patient comes back for a recanalization, the adjacent parts will be wide enough. अच्छे से recanalization will be able to achieve because you remove the thinnest part. On either side, you have nice wide portions. Okay, that is why isthmus is the preferred site of doing a tubal ligation because it is the narrowest part of the tube. This is a question in this year's NEET PG. Okay, this is the ampulla. C is the ampulla and D is the fimbrial end or the infundibular end. Okay. All are indications for expectant management of an unruptured ectopic pregnancy, except, is it because of mild pain? I mean, is it mild pain? Is it sac size less than 3.5 clinically stable? So it is mild pain. I told you no pain and no heartache, right? So no pain. Patient should be absolutely asymptomatic. So that ends ectopic pregnancy. Now we move on to molar pregnancy. Yes, I know we are running a little slow, but we also have to clarify our concepts well. So it's okay. Even if we have to sit for a few hours extra, I hope all of you are ready to sit for a few hours extra. Next is molar pregnancy. Molar pregnancy is again an important topic. Molar pregnancy, extra day to nahi lenge. We'll do a few hours extra every day and try and finish it. Okay. So I think till 12 we will study today. I hope that's okay with everybody. कोई call भी नहीं आया मुझे, है ना? That's an added advantage. So molar pregnancy is again an important topic. No class on 30th. Na 30th, 31st, 1st and 2nd is a nice, all of you have a nice Diwali break. Yes, 3rd is Sunday, 3rd we have a class again. But we're starting a little late because it is again festival day, na? It is Bhai Dooj. So I requested for a little late class, but I might start early depending on what time I get free. I'll let you know. Okay, now when we talk about molar pregnancy is a type of gestational trophoblastic disease Okay, GTD. Molar pregnancy is a type of gestational trophoblastic disease, and the WHO classification of gestational trophoblastic disease includes molar pregnancies and it includes trophoblastic tumors. In molar pregnancies, we have basically so uh, you basically have hydatiform mole, and this should come here. This is complete mole and partial mole. So there are two types of molar pregnancy, complete mole and partial mole. And then there is a separate type called an invasive mole. Invasive mole is actually a neoplasia. So if you club all these four together, these are actually gestational trophoblastic neoplasias. Okay. Invasive mole is basically a localized form of choriocarcinoma. Invasive mole is a localized form of choriocarcinoma. Choriocarcinoma is a metastatic tumor. If it's localized to the uterus, it's called an invasive mole. So basically, so this is the WHO classification. It's a little confusing, but just remember you have molar pregnancies. In molar, you have complete and partial. And then you have gestational trophoblastic neoplasias. In neoplasias, you have invasive mole, you have choriocarcinoma, you have placental site trophoblastic tumor, and then you have epithelioid trophoblastic tumor. Okay, so we will be discussing mainly molar pregnancies. The main set is molar pregnancies, and then we will be discussing a bit about the important points about GTN. So let's start with molar pregnancy. Molar pregnancy is a little tricky to understand. In that you should know what really happens behind this. Why does this form? This forms if we talk about a partial mole, hydatiform mole comes under molar pregnancy. Hydatiform mole के दो types है, complete mole और partial mole. एक bullet point से इनको इधर इधर खींच दो. Complete mole, partial mole are types of hydatiform moles. Now, partial mole is basically when two sperms fertilize one ovum. Okay, and this results in a triploid embryo. It could be XXX, it could be XXY, it could be XYY, depending on what fertilizes what. But remember, it is a triploid embryo. Okay, so it's 69XXX or 69XXY. And so it's easy to remember because partial mole is triploid. P and T come together in the nearby in the alphabet. So अगर भूल जाओ तो ऐसे याद रखो कि complete mole is diploid, C and D come together in the alphabet. Partial mole is triploid, P and T come nearby in the alphabet. ठीक है, complete mole में क्या हो रहा है? You have a sperm, ठीक है, fertilizing an empty ova. This ova is empty. It has no genetic material. Okay. So this sperm fuses with this ova and it undergoes something called androgenetic duplication. So it forms a diploid embryo which has no maternal component, only paternal component. It could be XX, or if two sperms, an X and a Y, fuse an empty ova, it could be XY also. Okay, so but it is diploid, 46XX or 46XY. So there is partial mole which is triploid, complete mole which is diploid. Now you should be able to understand the differences between both. The most important, of course, is the diploidy. Karyotype, the partial mole is triploid, complete mole is diploid. ओके वाई वाई नहीं हो सकता है, वाई एक्स चाहिए होता है, एक्स के बिना लाइफ नहीं चलती. वाई वाई कैन नेवर एग्जिस्ट, देयर हैज टू बी एन एक्स इन इट. ठीक है. नाउ कमिंग टू क्लिनिकल प्रेजेंटेशंस. Clinical presentation. So complete mole, one more time. Complete mole में ये होता है one sperm fertilizes an empty ova and this undergoes duplication and forms a diploid embryo which could be XX. Or the other scenario is two sperms, one X, one Y, or one X, one X, fuse with an empty ova. So this is called a dispermy. So you have again XX or XY embryo with no maternal component. ठीक है, हाँ XX हो सकता है, XY हो सकता है, YY नहीं हो सकता. Now coming to the clinical presentation. Now जो हम क्लासिकल प्रेजेंटेशन पढ़ते हैं, पैथोलॉजी में भी पढ़ा होगा, फाइनल ईयर गाइनी में भी पढ़ा होगा. यू मस्ट हैव सीन द grape like vesicle wala specimen also in your museum. Empty ova means no genetic material. It's a ova without a nucleus. ठीक है. So what happens is, in a complete mole, you'll see the classical presentation. What is the classical presentation? The woman will complain of passage of grape-like vesicles. Okay, when you examine her, the uterine height will be more than the period of gestation. The ovaries will show bilateral enlarged cysts called bilateral theca lutein cysts. You'll have the typical snowstorm appearance on the ultrasound. You'll have the typical association with preeclampsia, जो आजकल नहीं दिखता, because this is when these were diagnosed in the third trimester. Now we diagnose everything in the first trimester. But these are classical associations. Preeclampsia, hyperthyroidism, okay, hyperemesis gravidarum. These are classical जो picture था ना, जो description है molar का, that is usually with complete mole. Okay. Also remember, with complete mole, there is a higher risk of progression, or there's a risk of subsequent neoplasia. Choriocarcinoma इसमें ज़्यादा common होता है. Complete mole, the chance of it becoming a choriocarcinoma is higher. It is around 15 to 20% risk of GTN, gestational trophoblastic neoplasia. ठीक है. Now, partial mole is more subtle. Partial mole, most of the time you don't diagnose it पहले. आपने किसी पेशेंट को मिस्ड अबॉर्शन या ब्लाइटेड ओवम समझ के you did a DNC or DNE, and you send the products for histopathology, and then the pathologist calls you up and says ki this looks like a partial mole. So it's usually a diagnosis which is not made because of the clinical presentation. So it's the diagnosis, it presents similar to a missed abortion or a blighted ovum. Okay, it is not the classical grape-like vesicle wala picture. Uterine size is equal to POG. It is not more than the POG. Theca lutein cysts नहीं दिखते हैं. Medical complications नहीं होते हैं. And the risk to subsequent GTN is around 1 to 5%, not as high as 15 to 20%. So partial mole is of course milder, not as complex or complicated as complete mole. Risk to GTN is also less, and it doesn't have the typical picture of molar pregnancy. Now, the two most important, when the pathologist looks under the slide of those grape-like vesicles, उसको क्या देखेगा? उसको ये दोनों चीजें देखेंगे, villus edema and trophoblastic proliferation. These are your buzzwords in histopathology: villus edema and trophoblastic proliferation. In partial mole, they are focal. कुछ areas में देखेगा. But in complete mole, these two things are seen diffusely throughout the slide. उसको बस यही दिखेगा. ठीक है? Also remember, fetal parts. If partial mole goes on till the second trimester, sometimes fetal parts will form. So they are present. Here they are absent. Also, fetal RBCs can be present here. Here they are absent. Okay. Trophoblastic atypia. Atypical trophoblastic cells are present in complete mole, not in partial mole. Okay. Rakesh, clinical presentation of a partial mole is similar to a missed abortion. Similar का sign होता ना ये वाला, बचपन में लिखते थे, similar to a missed abortion. At least हम तो ऐसे लिखते थे. Then there is something which is very new. What is this new thing? There is an immunohistochemistry marker. IHC markers आजकल a lot of pathologists are doing. Similarly, if the pathologist is confused, suppose we have sent very little tissue for testing, and the pathologist is confused, doesn't know कि ये partial है या complete है. they can apply this immunohistochemistry marker. What is it called? P57 KIP2 staining. It will be positive in partial mole and negative in complete mole. Remember P for this and P for partial mole. Remember this immunohistochemistry marker is expressed only in maternal tissue. It is expressed only in maternal tissue. It is not expressed in paternal tissue, and hence it is present only in a partial mole. Okay, it's present only in a partial mole, not in a complete mole. So this is the difference between partial mole and a complete mole, which you should understand. Trophoblastic it appears in complete mole. I think main notes में ना गलत दिया हुआ है, ये इसको प्लस कर दो, वो टाइपो है. That's a typo in the main notes. Please correct it. Atypia, risk of malignancy is higher, ना तो atypia कहाँ दिखना चाहिए? Complete mole में. But yeah, this somebody had brought to my notice earlier. Please change this in the notes. QR notes में गलत है शायद से, main notes में ठीक है, कुछ ऐसा है. तो ये plus है, ठीक है? Okay. Now coming to the, so these things are important to understand because you can get a clinical question and they'll ask you what is there. Okay, so this is the snowstorm appearance. This question has come in every single paper in the last 5 years. या तो नीट पीजी में आता है, INI में आता है, FMG में आता है, but किसी ना किसी पेपर में this image is always there. So always know this image. This is a typical complete mole. Partial mole, you're not going to see this good a picture. This is a complete mole, the grape-like vesicles. And I think all of you have seen this in your museums, in your obs and gynae department, in those specimen jars. ये वाला जार तो होता ही होता है, या तो पैथोलॉजी में या ऑब्स एंड गायनी में. दिस इज अगेन अ कंप्लीट मोल, द grape like vesicle classical presentation which is seen. So you should know these two images. This is the histopathology of the grape like vesicles. This khali jagah is the villus edema, and ये जो pink cells है all around, this is the trophoblastic proliferation. So trophoblastic proliferation, villus edema. Remember these trophoblastic अगर मैं रात को भी तुम्हें नींद में उठाऊं, you should tell me and I ask you कि क्या है, what is in molar pregnancy, you should be able to tell me trophoblastic proliferation and villus edema. ठीक है? Now risk factors is not important. Okay, this is nothing, this is not important. It's just a random theoretical wala slide. So isko main skip kar rahi hu. What is more important is how the patient will present. So same thing, delayed periods, bleeding and pain, like in ectopic pregnancy, like in abortion, similar. So bleeding in the first trimester especially, or bleeding less than 20 weeks, always think of abortion or ectopic or molar pregnancy. Along with that, significant nausea and vomiting. Hyperemesis gravidarum is typically associated with molar pregnancy. Large uterus, bilateral cystic ovaries, no fetal heart on auscultation, especially if the patient presents later in pregnancy. She comes to you, unbooked patient, बहुत आते थे, पहले आते थे, अब कम आते हैं somehow. Because awareness is increased, patients are getting scans on time. But I have seen so many patients who come to you at 24, 28, 30, 32 weeks also. I think the highest I've diagnosed a molar pregnancy which has gone unbooked till 32 weeks. When you examine uterus is 32 weeks, jab auscultate karo, nothing is heard because there's no fetal heart. It's all grape-like vesicles. Okay, then thyrotoxicosis and preeclampsia. Okay, so how will you diagnose this? Beta HCG levels are very, very high. They are more than 1 lakh. Okay, usually if you do the serum beta HCG, you will find they're very, very, very high levels. Sometimes they are so high that जब आप UPT करोगे, UPT negative दिखेगा because this is called the hook effect. Excessive beta HCG can actually cause a negative urine pregnancy test because it sort of oversaturates the assay. All the antibodies get picked up and it oversaturates the assay. This is called a hook effect, where very high levels can cause a negative urine test. But if you are highly suspicious, always get a serum beta HCG. Anyway, we need a serum beta HCG because this is going to help us in follow-up. Ultrasound pe you'll see snowstorm appearance, and in partial mole you can see fetal parts along with the grape-like vesicle वाला picture. दोनों चीजें दिखेंगे. ठीक है? And on histopathology, trophoblastic proliferation and villus edema. Okay. Now, you'll see in both, Pache, in partial, you'll see it in focal areas, and in complete, you'll see it diffusely. Okay. Now, coming to management. Management mein, what is the management of molar pregnancy? What will you tell me? You will say you will do a dilatation and evacuation. You have to evacuate the uterus. You have to evacuate the contents of the uterus. Okay, pre-operatively, you will have to get lab work done, get a chest x-ray done, and consider dilatation of the cervix prior. This is from Williams. Williams में क्या, America में क्या use करते to dilate the cervix? They use laminaria tents. What are laminaria tents? They are hygroscopic dilators made of seaweed, and वो हम cervix में insert करते हैं. They dilate the cervix. पर India में available नहीं है. India में we can use misoprostol, that is PGE1, to dilate the cervix. And then intra-op, we will use the Hagar's dilator, the metal dilator, to dilate the pregnancy, to dilate cervix. Nandini, yes, X-ray in pregnancy. Why? Because fetus थोड़ी है. We're not worried about fetus ना. हमें तो ये निकालना है जो भी है अंदर. ठीक है? Now intraoperative, what will you do? You also, what are you worried about? You have a huge uterus, which is very big in size, where all you have inside are grape-like vesicles, okay? And you have to evacuate this. Now, when you're evacuating a molar pregnancy, you are worried about a few things. एक तो ये बड़ा uterus है, बहुत soft uterus है. So chance of perforation during the procedure is very high, more compared to other pregnancies जिसमें आप DNC करते हो, ठीक है? The other risk you're worried about, yes, is hemorrhage. It can bleed. I have seen patients, this 32 weeks wala molar which I'm talking about, bled extensively. Okay, so you have to be very, very worried about hemorrhage and perforation. But it's the same thing. When I say dilatation and evacuation, please understand the cervix is not dilated. So I have to dilate the cervix and then I have to evacuate. How will I evacuate? I will do a suction evacuation. Okay. So when I say suction and evacuation, it basically means the same thing. Plus, in addition, dilatation bhi karungi. So it's the same thing. DNE, suction evacuation almost means the same thing. Okay. Now, what are the precautions I will take ताकि ये दोनों चीजें ना हो. सबसे पहले I will keep the patient with large bore IV cannulas, because if she bleeds, then I'll be able to resuscitate her quickly. Always do it under anesthesia, this procedure. Okay, before starting, always start oxytocin, oxytocin infusion start karo for the patient. Okay, because this is going to help contract the uterus. Then what do? Always keep other uterotonic agents also ready, so that PPH या PPH नहीं कहोगे इसमें, but bleeding नहीं होगा, the uterus will contract. How will you do the suction evacuation? You will use the manual vacuum aspirator or the electrical aspirator, but the instrument you will insert inside the uterus is called the Carman's cannula. You will insert the Carman's cannula. Okay, and very important, you will insert it just beyond the internal os. पूरा यहाँ तक लेके insert, पूरा अंदर तक aspirator नहीं डालोगे. You will put it just beyond the os, switch on the machine, all the products come out, okay, and the uterus will contract over. Suppose your instrument went till here and you started the process. What's going to happen as the uterus comes down in size? It's going to perforate it's going to perforate the uterus. Okay, so just be little bit beyond the os. You don't want to cause a perforation, so don't go beyond the internal os too much. Okay, the oxytocin is going to help contract the uterus so that she doesn't bleed. Okay, that's the important thing you have to keep in mind. So, and it has to be ultrasound guided, so you know when to stop the procedure when everything has come out. Also, at the end of the procedure, you will do a gentle curettage. There is an instrument called a uterine curette. I'm sure most of you have seen this, where you have a blunt end and you have a sharp end. So, using the blunt end of the curette, you will do a very gentle curettage, not a vigorous curettage. हल्के से curette करोगे. This will ensure completeness of the procedure and that nothing has been left behind. So, your main worry is basically perforation and hemorrhage. These two you have to be careful about. For preventing hemorrhage, you have to keep your oxytocin and other uterotonic agents like methergin, like prostadin, like misoprostol ready. And to prevent perforation, your cannula should be just beyond the internal os. These are the precautions you will take. Now, what else is the, are we done? No, we're not done. If she is Rh negative, give her anti-D. Okay. Initiate effective contraception other than an intrauterine device. You can give any contraceptive for her, including contraceptive pills. Okay. Very importantly is the last point. Okay. The last point is very important. आपने सक्शन इवैक्यूएशन किया या डायलिटेशन इवैक्यूएशन किया, उसके बाद आपने क्या करना है, यू हैव टू कीप द पेशेंट ऑन बीटा HCG surveillance. Why should the patient be on surveillance? Because in a complete mole, there is a 15 to 20% risk of malignancy, and in a partial mole, there is a 1 to 5% risk of malignancy. So, how do we do the surveillance? We do weekly. We had a baseline beta HCG. ठीक है. So pre evacuation हमारे पास beta HCG value था. ठीक है. Pre evacuation. Then 48 hours evacuation we take another beta HCG sample. Then we do weekly beta HCGs till the beta HCG becomes 0. And then we do monthly beta HCGs for 6 months. This is called beta HCG surveillance. Why is this important? Because agar beta HCG बढ़ने लगता है blood में, that means this mole has been transformed to choriocarcinoma. So again, pre-evacuation beta HCG, post-evacuation beta HCG, and then weekly beta HCG till 0, till the beta HCG disappears from the blood, and then monthly for 6 months. This is called as beta HCG surveillance, and for this we do this. It's called a log regression curve, and when I was a resident, we used to give this, we used to, जो graph paper मिलता है ना market में, you get a graph paper maths में, याद है वो green color की sheet होती है. We were supposed to give each patient of molar pregnancy evacuation this graph paper and plot this chart in her file. So whenever she would come to the OPD, we would plot the beta HCG level and see कि कैसे कम हो रहा है. So this curve shows you. So this is, for example, pre-evacuation, it was 1 lakh. Then 48 hours after evacuation, this is the value. And this is 10 lakh, na? This is 10 lakh, na? This is, I get confused here, lakhs or millions mein. This is 10,000, this is 100,000, this is 1 million. So I know the million system. So this is post-evacuation. Okay. So it's come down to 100,000 from 1 million. उसके बाद क्या होता है? उसके बाद you will do weekly beta HCGs, 1 week, 2, 3 week, 4 weeks. So normally a partial mole will come down to 0 by 7 weeks. And a complete mole या Zambia effect ना, तुम नहीं, मुझे lakhs और crores बिल्कुल भी नहीं समझ आता. And a complete mole will come back to normal by 9 weeks roughly. This is around about itna आप expect कर सकते हो कि 7 weeks partial mole will come down quickly because the beta HCG is not so high to begin with. Complete mole takes about 9 weeks to come back to normal after evacuation. Now, while you are plotting this evacuation, this log regression, this regression curve, suppose the beta HCG starts rising again. Okay? Or suppose the beta HCG plateaus. Okay? Or even after you're doing this weekly, even after 6 months, beta HCG is still present in the blood. It hasn't become zero. Then you will diagnose this patient to have choriocarcinoma. So choriocarcinoma is diagnosed when, okay, so choriocarcinoma is, I think the slides are with oncology wale slides, but I will cover a bit of it here. Choriocarcinoma is diagnosed when either the beta HCG is rising or the beta HCG has plateaued, okay, or beta HCG is still present in the blood even after 6 months of evacuation, okay, or beta HCG, or if the patient comes with a bout of bleeding, okay, during this whole surveillance, she comes with a bout of bleeding, you do a scan, you find uterus mein kuch hai, you do another evacuation, and that you send for histopathology, and that comes as choriocarcinoma. That means you have histopathological confirmation of choriocarcinoma. Any of these four, it is a diagnosis of choriocarcinoma. Okay, so beta HCG rising, beta HCG plateauing, beta HCG still present in the blood even after 6 months of evacuation, or you have a definitive histopathological confirmation of choriocarcinoma is your diagnosis of choriocarcinoma. Okay, previous slide, yellow. Correct, Pushpender. Increase can also mean she got pregnant. So when a patient comes who is on this follow-up and the beta HCG is increasing, the next best step is, of course, rule out pregnancy. So when I say beta HCG increasing, there is a criteria. The increase should be over 3 weeks. Okay, it should be gradually increasing, and you have to, of course, rule out pregnancy. You are not wrong, you are correct completely. Okay. And that is why we tell the patient, don't conceive for during the surveillance time, usko pregnant nahi hona. That's why effective contraception has to be given. OC pills are completely safe, they can be given. If she gets pregnant, then you continue the pregnancy or advice. The only thing, it interferes with your beta HCG surveillance, because as he said, beta HCG बढ़ गया. So now you're confused. Is it pregnancy or is it choriocarcinoma? Then you'll do a scan. If you see if you see a gestational sac, you know it is pregnancy. Yes, the ovarian cysts will regress by themselves. The beta HCG will settle down. The ovarian cysts will regress. Okay, a woman came with intractable vomiting. Ultrasound shows snowstorm appearance at 6 weeks. Next step in management is suction and evacuation. So this is a complete mole. What will you do? You will evacuate the uterus. Which of the following is not included in GTN? GTN में क्या नहीं आएगा? Gestational trophoblastic neoplasia में partial mole नहीं आएगा. Partial mole, complete mole are types of gestational trophoblastic disease. Tumors and neoplasias include all the rest. Partial mole is triploid, 69XXX. All are true regarding mole except karyotype in partial mole is triploid, correct. Theca lutein cysts are common in complete mole, correct. There is evidence of some fetal tissue in complete mole, this is wrong. There is diffuse trophoblastic hyperplasia in complete mole, this is correct. Okay. 36-year-old woman presents with this picture, vaginal bleeding, 3 months pregnancy. What is the best treatment option? Again, this is the AIIMS INI question. So very simple questions you get. You shouldn't get these questions wrong. This is a suction, evacuation, snowstorm appearance. All are seen in complete mole except absent fetal RBCs. So fetal RBCs will be there only in partial mole. There'll be some fetal tissue, including RBCs. Diffuse proliferation is seen, marked atypia is seen, but positive KIP2 नहीं होता, negative होता. Remember, P for this and P for partial mole. It is not seen in complete mole. Okay, so GTN is left. GTN we'll discuss in the oncology or maybe the END. Don't worry, it's a small topic, hardly 5 minutes. But let us continue with now diagnosis of pregnancy. Now we come to normal pregnancy. ठीक है, जो शुरू में करना चाहिए था, but I like teaching this at this point. Once you've done all the complications, now we can आराम से sit and discuss normal pregnancy. ठीक है, कि नॉर्मल प्रेगनेंसी में क्या करना होता है, what are the how do you diagnose pregnancy, how do you examine pregnancy, immunization, ultrasound, screening, testing, all those things. ठीक है, so it is not, it's a very light topic, so even if you're tired you can just switch off and listen. Okay, so now coming to diagnosis of pregnancy. Diagnosis of pregnancy is very important from the exam point of view, especially the examiners like asking from this table. Why they like asking from this table, I don't know, maybe because they like the named signs. But हमेशा पूछते ही पूछते हैं, although we don't do these. Now, if a patient comes to you and she says that I think I'm pregnant, आप क्या करोगे? आप बोलोगे एक pregnancy test करो, pregnancy test positive है, you will get an ultrasound. Straightforward, है ना? But when we were postgraduates, and I told you I'm very old, when we were postgraduates, I remember a professor of mine, she used to say, always examine the patient, always examine the patient, 6 weeks patient, 8 weeks patient. We would be doing speculum and PV. So it was good in a way. We used to see all these signs, but they're not really done. They're just there for knowing that these signs exist and were used in a time when investigations were not available. ठीक है? So सबसे पहले, these are first trimester signs of pregnancy. What are the trimesters of pregnancy? First trimester is till, it used to be till 12 weeks. Now we say till 14 weeks is the first trimester. Second trimester is 14 to 28 and third trimester is 28 till delivery. ठीक है? So first trimester, yeah, like lash and lash, correct. So first trimester में अगर पेशेंट को आप एग्जामिन करोगे, आपको क्या क्या दिखेगा? सो दिस लास्ट वाला कॉलम ना, just generalize it. You don't have to remember the exact weeks. Most of them are seen between 6 to 10 weeks. कुछ ऐसा particular नहीं है कि 8th week में दिखेगा या 6th week में दिखेगा. Just remember, generally all are seen between 6 to 10 weeks. ठीक है? Now the first is Jacomere or Chadwick sign. What is Jacomere? Both people describe them. This is bluish hue of the anterior vaginal wall. Why? Because it's very, very vascular. So the vagina appears blue in color. This is an inspectory finding. On speculum examination, it is a vaginal sign. Osiander sign क्या है? Ossi said that if you put your hand if you do a vaginal examination and you put your fingers in the lateral fornices, ठीक है? Lateral fornices क्या होता है? So what are these fornices? When you do a PV examination, okay, this is what you're feeling. Your finger is here, ठीक है ना? Finger ये है आपका. तो आप क्या फील करते हो पीवी में ना? ऑल ऑफ यू एज अंडर ग्रेजुएट, आई थिंक ऑल ऑफ यू मस्ट बी रियली वंडरिंग कि कर क्या रहे हो पीवी में, है ना? सो दिस इज what I always used to think when I became a postgraduate resident. तब भी मुझे like it takes time to understand things ना. So now I am in a position where I can explain to you properly. So you feel the cervix, of course, है ना? तो ये cervix है, but this is a 2-dimensional diagram. Imagine this in 3D. In 3D you have a space, this space in front of the cervix, this is called the anterior fornix. You have this space behind the cervix, this is called the posterior fornix. And then you have space laterally also. ऐसी space laterally पे होता है, which are called the lateral fornices. तो lateral fornices में when we do a PV, and why do we palpate lateral to the uterus? Because if there's any adnexal mass, ovarian mass, you will be able to palpate it through the lateral fornices. Also, in this Osiander sign, जब हम lateral fornix में finger रखेंगे, तो थोड़ी देर के लिए रखोगे, what will you feel? You will feel pulsations. These are pulsations of what vessel? अब वही ना समझ नहीं आता विघ्नेश्वर, राइट ना, ऐसा एक बार करा भी देता है ऐसा, आपको समझ नहीं आएगा. नॉट द इंटरनल आइलैक आर्टरी अंजलि. लैटरली क्या, कौन सा वेसल आ रहा है लैटरली? Which vessel is coming here? What is the main blood supply of the uterus? It is the uterine artery. You're feeling the uterine artery, and these pulsations are basically pulsations of the uterine artery, which is now enlarged in size. Okay, remember, more blood flow is flowing through the uterine artery, and hence you can nicely feel these pulsations. Okay, this is the Osiander sign. So these two signs are vaginal signs. Then you have one cervical sign. Okay, Goodell sign is a cervical sign. It is a soft cervix. So when you touch this cervix, जब मैं अब सिखाती हूँ, I tell my residents that when you do a PV in a non-pregnant uterus, the cervix feels like the nose. It exactly feels like this. But if you touch the cervix in a pregnant uterus, it feels like the lips. It is very, very soft. So this is called the Goodell sign. It feels like the lips. A gynae uterus cervix will feel like the nose. So Goodell sign is a soft cervix. Okay. Then you have three uterine signs. What are the three uterine signs? The Pisca-Seck sign, the Hagar sign, and the Palmer sign. Now, इनमें सबसे important है, and when I say uterine sign, I basically mean this examination. This is the bimanual examination जो मैं बोल रही थी ना. This is a bimanual. 2 fingers in the vagina, 1 hand on the abdomen. You're trying to feel the uterus between your hands. This is called a bimanual examination. This sign which is being shown here is the Hagar sign. This is the most important sign. What is Hagar sign? Hagar sign is if you approximate the uterus between your fingers, you will find that the fingers are approximating between the body of the uterus and the cervix, beach mein, at the isthmus. This is because the body becomes very, very soft. So your fingers approximate between the body of the uterus and the cervix. This is called the Hagar sign on bimanual palpation. On bimanual exam, the abdominal and vaginal fingers appose below the body of the uterus. ठीक है, ये around 8 weeks पे दिखता है. Wait, between 6 to 10 weeks, remember all. What are the other signs? What is Palmer sign? Palmer sign is अगर आपका अपना हाथ ऐसे few minutes के लिए रखोगे, you will able to, I've never appreciated this myself because I've never kept my fingers for so long. The patient will be very uncomfortable. But if you keep it for a few minutes, you will feel little contractions. Okay? So you apparently you will be able to appreciate this. Little the uterus will be contracting, rhythmic uterine contractions elicited. ठीक है, Palmer sign होता है ये. And एक Pisca-Seck sign है. Pisca-Seck sign होता है. Okay, sorry. So Hagar sign, Pisca-Seck sign क्या है? Pisca-Seck sign होता है if the embryo is implanted towards one side. मतलब एक कोने में जाके implant हो गया है. What you will find is you'll find asymmetrical uterine enlargement. Okay, it will be the uterus will feel bigger on one side or asymmetrically enlarged होगा. So just remember these because they need to be remembered and they can be asked, but they come in every exam I've seen, especially the INI people like asking this. They can form a lot of questions from this area, probably that's why. But these are first trimester signs of pregnancy. In the second trimester, what happens? In the second trimester, the patient, in symptoms, the patient will have amenorrhea. She will feel quickening. What is quickening? Quickening is when she first appreciates fetal movements. Okay, that is called as quickening. In a primigravida, this appears around 20 weeks. of pregnancy. In a multigravida, this will appear at around 18 weeks of pregnancy. Okay. In a non-pregnant Disha, by manual examination, you will feel a firm uterus, soft नहीं होगा एक तो, and it will be normal size. It won't be बढ़ा हुआ. बढ़ा हुआ कैसे बताओगे? वो आप खुद करोगे तो आपको समझ आएगा कि normal uterus और 8-week size uterus में क्या difference है. I can't explain it like this. You have to do it yourself to understand. But yes, a non-pregnant uterus will be firm. Okay. Then the abdomen will enlarge, and then she'll have symptoms of frequency of maturation, which is maximum in the first and the third trimester. Frequency of maturation is maximum in the first and the third trimester of pregnancy. What are the signs in the second trimester? Chloasma, darkening of the skin. Okay, breast changes become more prominent. Then these both have come as questions: external ballotment, internal ballotment. Both are second trimester signs. External ballotment appears at 20 weeks, 20 to 28. You can say internal ballotment is 16 to around 24 weeks. What are they? This is external ballotment. Ballotment basically means bounciness. So if you move the baby with this hand from here, you will feel it hit or tap against your finger or your hand on this side. This is called as external ballotment. It can be appreciated between 20 to 28 weeks of pregnancy. Just move the baby like this, it hits you. Move like this, it will hit you here. It's basically something floating in fluid. The baby is floating in water. So that water media makes this ballotment possible. Yes, juggling from one side to the other. Similarly, internal ballotment. This is below. You do a PV and you just slightly above the cervix, you give a tap like this. So the baby will go up and come and hit your finger back again. This is called as internal ballotment. ये थोड़ा जल्दी पता चलता है और बहुत लेट तक नहीं पता चलता because once the baby becomes bigger and bigger, आपकी ये टैप से हिलने नहीं वाला. It's going to become bigger, so you require more force to push it. So 16 to 24 weeks पे, yes, something like fluid thrill. You will be able to feel it between 16 to 24 weeks. Both have come as questions in some form or the other. So you should know when you can do these tests. They are tests of the second trimester of pregnancy. What is the most definitive sign? This is a NEET PG question asked 7-8 years back. What is the most definitive sign of pregnancy? Very good. It is fetal heart rate. You're able to auscultate the fetal heart rate or fetal heart sounds. If you're able to hear the fetal heart, this is the most definitive sign. External ballotment is present in ascites with a tumor. Internal ballotment भी कोई भी ascites with a pelvic tumor, you'll be able to get this. Fetal parts, a large irregular fibroid may mimic fetal parts. So these are not definitive signs. But auscultating a fetal heart, auscultating another heart inside the abdomen cannot be seen anywhere else, right? So most definitive sign is auscultation of a fetal heart rate. The earliest you can auscultate by a stethoscope is 20 weeks. You can auscultate with a stethoscope. If you're using a Doppler, you can auscultate even earlier, around 16 to 18 weeks. You'll be able to hear the fetal heart if you're using a Doppler machine. Okay. Now coming to ultrasound in the first trimester, we've discussed ultrasound, hai na? Second, third trimester mein what do we do? We usually, so when all do we do scans in pregnancy? When do we do ultrasounds in pregnancy? We usually get the first ultrasound done, so you get an early ultrasound to diagnose pregnancy, usually between 6 to 8 weeks. This is also the viability scan where you are seeing the cardiac activity, the heartbeat. You are also seeing the CRL, crown rump length. Okay, and the crown rump length is the best way to date the pregnancy. Remember, if the patient is not sure of her last menstrual period, or if she's had irregular cycles, the best way to date the pregnancy, yes, this is a transvaginal scan ideally. Okay, the best way is to measure the crown rump length. Suppose you measure this, it comes as 12 millimeter. So the software will tell you that 12 millimeter corresponds to say 8 weeks. I'm just telling you, I don't know kitna correspond hota hai. ठीक है? So and suppose the patient was 10 weeks. So there is now a disparity. By dates, she's 10 weeks. By ultrasound, she's 8 weeks. Which one should you follow? You should always follow the dating by the CRL. This is the most accurate dating, and this question also comes in every paper. The most accurate estimation of gestational age is by the crown rump length, ideally done at around 8 weeks of gestation. Okay. The second scan we do is usually at 11 to 14 weeks, which I've already told you. So many things we see. We see Down syndrome screening, prediction of preeclampsia. We do cervical length. We also look at the chorionicity in twin pregnancy. Okay. Third, क्या करोगे? Third, will do a scan at 18 to 22 weeks. This is called the TIFA. TIFA क्या होता है? Targeted imaging for fetal anomaly. Okay, this is also called the level 2 scan, right? Where you are looking for structural fetal anomalies. So this is also a very important scan. Then the remaining scans जो होते हैं third trimester में, usually we get a scan done around 28 to 30 weeks, and then we get a scan around 36, 37 weeks. But जो बाकी scans है ना, so we get a scan done at term, that is 37 weeks. These other scans are very variable. You can choose to get more, you can choose to get less. These are basically to look for fetal growth and fetal well-being. But these are your basic scans, right? It is, Mahesh, it is routinely done. You have to have a 6 to 8 week scan. An early scan not only tells you the cardiac activity, it tells you the dating, it also tells you if there's one baby or two babies, it tells you if there's any adnexal ovarian lesion. Okay, it tells you so many other things. So it has to be done. Then the 11 to 14 weeks has to be done. The level 2 has to be done, and then third trimester growth scans, at least 2 growth scans have to be done. Okay. So TIFA is done between 18 to 22. You can make this 22 weeks. 11 to 14 weeks scan, Prashant, I'll tell you in detail abhi thodi der mein, theek hai? So for gestational age estimation, CRL kab karte hain? Crown rump length can be taken from anywhere from 6 to 14 weeks of pregnancy. 6 weeks is when the embryo appears till 14 weeks of pregnancy. 14 weeks के बाद कौन से parameters लेते हैं? We take, remember yesterday I told you BPD, HC, AC and femur length. ठीक है? So in the second trimester, which is the most accurate for gestational age, it is the biparietal diameter. And which is the least accurate for gestational age measurement? The least accurate, that is the one with most variation, is the abdominal circumference, because the AC is not a bony diameter. All the rest are bony. Biparietal diameter, head circumference, femur length, these are all bony measurements. Abdominal circumference depends a lot on how fat or thin the baby is. If it has more abdominal fat, it will be bigger. So it is not a good measurement for looking at the gestational age. Yes, बच्चे Karan, CRL is the most accurate, but CRL हम सिर्फ 14 weeks तक लेते हैं. जब बेबी 14 weeks से ज्यादा हो जाता है, crown rump length is not possible to measure. The baby becomes so big. It is a measurement which is only taken between 6 to 14 weeks. It is not taken beyond 14 weeks. So if you want a good gestational age accuracy, the patient should have a first trimester scan. Okay. Now, coming to obstetric examination in the second and third trimester, I've already discussed this yesterday with you, so I'm not going to discuss again. Remember, I had told you uterine height. So the first thing we do is the uterine height. I already told you uterus कब palpable होता है 12 weeks पे. ठीक है, or should I quickly just revise this? It reaches the lower border of umbilicus at 20 weeks, upper border at 24 weeks, Ziffy sternum at 36 weeks, 28 यहाँ पे, 32 यहाँ पे. Then at term it becomes small and it comes till down till 32 weeks and the flanks become full. So I'm not going to repeat all this, but we check the uterine height. So you should know the causes of uterine height less than the POG and causes of uterine height more than the POG. Both you should know because they can come as questions. ठीक है. The second thing we do is the symphysiofundal height. This also I discussed with you yesterday. If the disparity is more than 3 centimeters, then you should suspect fetal growth restriction. This is the main use of symphysiofundal height. It is valid between 20 to 36 weeks. The symphysiofundal height in centimeter should correspond to the period of gestation in weeks. So if she's 20 weeks, the symphysiofundal height should be 20 centimeter. If she's 26 weeks, it should be 26 centimeter plus minus 3 centimeter to take into account the maternal obesity. Okay, so that is what you do in the beginning, and I think all of you know this from final year. सबसे पहले uterine height देखोगे, फिर symphysiofundal height देखोगे, फिर आओगे on your Leopold maneuvers. Now this is very important to understand, so we'll spend some time on the Leopold maneuvers. In the Leopold maneuvers, remember these are done after 28 weeks of pregnancy, and the Leopold maneuvers are used to determine several things. They are used to determine, number one, the lie of the baby. Is the baby in longitudinal lie? And we'll be doing these definitions tomorrow. The lie, the presentation. But roughly, I think you know. Anna, is the baby in longitudinal lie, oblique lie, transverse lie? Second, we also get to know the presentation of the fetus. Is it cephalic presentation? Is it breech presentation? We get to know by the Leopold maneuvers. Okay, third thing, we get to know which side is the back. Okay, why is it important to know which side is the back, especially in longitudinal lie? Because by knowing which side is the back, you know where you are going to put your stethoscope. Also, you know which side is the occiput, because जहाँ पे back होगा उसी side पे baby का back of head भी होगा. So you know which side is the occiput, you know which side to auscultate the fetal heart rate. And you also know whether the presenting part has entered the pelvis or not. Okay, these are the things you get to know by doing the Leopold maneuvers. Just a second, please.
नहीं चली गई बेबी
Okay, just ignore my son. He's sitting with me. Okay, he sits very often in my classes because he likes listening to what I teach. But just ignore him, okay? So what we do is what we do in Leopold maneuvers is we we need just move your legs to the side. It's okay. Yeah, sit like that. Okay. So in Leopold maneuvers, the first maneuver, this is the first maneuver. The first maneuver, what we do is we do the fundal grip. In the fundal grip, what we're doing is we are palpating the fundus of the uterus, okay, like this. We put our hands on the fundus of the uterus to determine what part is lying in the fundus. Now, if like in this picture, the breech is in the fundus, what are we going to feel? We're going to feel a firm, okay, we're going to feel a firm, broad, non-ballotable structure. Remember, the breech is very wide, तो वो ballotable नहीं होता है. Okay, so in the fundal grip, this is going to tell us which part of the fetus is occupying the fundus. If it is the breech, you will feel it as a firm, broad, non-ballotable structure. But if it is the baby's head, suppose it was a breech presentation. Breech presentation hota to yahan pe head hota hai. So the head would have felt as a hard, ballotable structure. You can keep your feet down.
Comfortable with this plant here.
Take out the plant. Yeah. You can put your feet down. Keep your feet down. Yeah, keep your feet down. Okay. So if it is the head, it is a heart. आपको जाना है?
नहीं.
कहाँ बैठोगे बेटा? यहाँ मुश्किल हो रहा है ना? यहाँ पे बैठो.
हाँ, ऐसा ठीक.
ऐसे ठीक हो? पक्का? Okay. So if it's the head, it's a hard ballotable structure. Okay, it's a hard ballotable structure, and this will tell you what part is occupying the fundus of the uterus. Now the second grip is this one. This is the second grip. Can you see it's the lateral grip? The lateral grip tells us which side is the back of the baby and which side are the limbs. How will we know this? The back will feel smooth and regular, and the limbs will feel irregular. So this is telling us which side is the back, which side is the limbs. Okay. Then you have the third and the fourth grips. Now these are also called as the pelvic grips. So the third Leopold maneuver is also called the first pelvic grip. This is also called the Pollick's grip. Okay. And the Pollick's grip is the one done with only one hand. Because you put your hand in the pelvis and you try to palpate what is there. If it is the head, you will find a hard, ballotable structure. This is the fetal head. Okay, but if it's the breech, suppose it's the breech will feel like a firm, broad, non-ballotable structure. So the first pelvic or the Pollick grip or the third maneuver is telling us what? It is telling us the presentation, the part of the fetus occupying the lower pole of the uterus. Okay? The fourth grip, this is the fourth grip. This is also called the second pelvic grip or simply the pelvic grip. Okay, so if I say pelvic grip, it means the second pelvic grip. This is the only maneuver which is done by turning ulta. We turn towards the feet of the patient and we try to approximate our hands and try to see if they are approximating or not. If we can approximate our hands, that means the head is high. It hasn't entered the pelvis. So if you can approximate your hands, the head, or if your hands are converging, the head is high. But if you are unable to approximate your hands, they are diverging. That means the head has entered the pelvis. Okay. I mentioned the earlier names wrong in second and third interchange. नहीं मैंने कुछ गलत mention नहीं किया, जिगर समझ नहीं आया. So the fourth grip in the second and third I mentioned ulta. The first is the fundal grip. All are okay now. First is the fundal grip. Second is the lateral grip. Third is the first pelvic grip, also called the Pollick's grip, also called the third maneuver. So the third Leopold's maneuver is also called the first pelvic grip. It's also called the Pollick's grip. This is telling us the presentation of the fetus of the fetus, and it is done with one hand. Okay. If it is the head, it will be hard and ballotable. If it is the breech, it will be firm, broad, non-ballotable. And the fourth grip is also called the second pelvic grip or just the pelvic grip. Here you turn yourself towards the feet of the patient and you try to approximate your hands. If they approximate, the head is high. If they don't approximate, the head has entered the pelvis. So how can a question come from here? They can simply ask you a picture, show you the image and say ye kaun sa grip hai. This has commonly come in the past. Or if you want to make a clinical question, they can say a patient came at 32 weeks and on the Leopold's maneuver, the fundal grip showed a hard ballotable structure. What is the presentation of the fetus? That's also how a question can come. So if I say the first grip shows a hard ballotable structure, what is the presentation? The presentation is breech, correct? So the fundal grip is showing a hard, that means fundal grip पे head है. तो presentation क्या होगा? Presentation breech होगा. Okay, yes, the knees have to be flexed to do the maneuvers because that will relax the abdomen a bit. Okay, so remember that's how questions can come from these maneuvers. That's why they're important. There's always ways to make viva questions into MCQ questions. Difference between first and third. First and third में बच्चे उल्टा है ना. First is fundal, third is the pelvic grip. Okay, yes, it of course it. I know what you're saying. It implies that जो fundus में होगा उसको opposite pelvis में होगा. So what you're saying does make sense है ना कि it's the same thing but ulta. Yes, both tell the same thing. It's just confirming your finding in a way. ठीक है? Okay, now coming to the next thing. The next thing now what we're going to discuss, the remaining part of our lecture today is all this. So we'll try to finish this in an hour. Let's see how much we can do. The first is preconceptional counseling. Then we will be discussing how to calculate the parity index, how to write the obstetric formula, then calculating the EDD, then a bit about iron and calcium and folic acid, immunization, and here we'll be mainly discussing Down syndrome screening. Okay, then I have some images in the end, which maybe we can do tomorrow or today. Let's see how, depends on how much time permits. Chana sone ke liye? Okay. So let's cover the preconceptional care. Preconceptional care may there are two. So he wants to become a gynecologist. For those of you who don't know, he really wants to become a gynecologist, है ना? Yes. Okay. So recommendations for preconceptional care. The two important things you need to remember. One we have discussed, but we'll discuss today. The questions that come are folic acid supplementation and the second is rubella vaccination. ठीक है, कोई pressure नहीं है इस पे. He really wants to become a gynecologist, although I don't want that. है ना? Okay. So folic acid supplementation is very important. What is the proven health benefit? It reduces the incidence of neural tube defects. That is the benefit of folic acid supplementation. By how much? By almost 70%. Now, kitna dena hai or kisko dena hai, that is important. We have to give, in low risk women, we give 400 microgram per day. In high risk women, we give 4 milligram per day. Some guidelines will say 500 microgram and 5 milligram because that is the actual dose available in most tablets. Okay? And when should you start? You should start at least 3 months prior to conception and continue for 3 months post conception. So 3 months पहले से start करो till 3 months after. Now, what do you mean by low risk and high risk? That is the next question. What do you mean by high risk women? Which women constitute high risk? So high risk women are those women who, number one, have a previous baby with a neural tube defect. Okay. Second, those who have overt diabetes mellitus. I told you, no, most common anomaly is heart disease, but second most common anomaly is neural tube defects. Third, those who are on anti-epileptic drugs, because most anti-epileptic drugs are going to cause neural tube defects. What else? If this she's a known case of folic acid deficiency, suppose she's anemic and you work her up and you find she's folate deficient. The fifth, women who have obesity. Okay, these women also you will want to give a higher dose. Yes, especially maximum risk with sodium valproate. Correct. What else? Anything else? Women, yes, over diabetes हो गया बच्चे, DM, diabetes mellitus. Now, what else? What else? So, one more I want to add here is women who have a hemoglobinopathy, like sickle cell disease or thalassemia. What happens in these women? That the turnover rate of RBC production is higher. AED is anti-epileptic drug, women on anti-epileptic drug. So women who have a hemoglobinopathy, usually the red cell production is higher. So more folic acid is required and these women tend to be folate deficient. So these group of patients, especially the first four groups, okay, are the ones which, why am I saying especially the first four groups? Because एक बार एक question आया था, FMG में आया था, where they had given all of the options. I mean, 5 of these options. ये वाला भी था, sickle cell भी था और 3 और थे. And then they asked which one will you not give high dose. So priority is these 4 and then the other ones. Okay. Yes, folic acid 3 महीने पहले से देना है till 3 months after. So the first 3 months till 12 weeks of pregnancy, she has to get the folic acid. So these are the women you will give 4 milligram or 5 milligram per day of folic acid. To all other women, you will give 0.4 or 0.5 milligram per day. The second important intervention is rubella vaccination, which we have discussed. If any woman who comes to you planning pregnancy, get an IgG rubella done. If it is negative, give her the rubella vaccine, but tell her not to get pregnant for at least 1 month. But if she does get pregnant, rubella vaccine plus advice on not to conceive for 1 month, because it is a live vaccine. There is a theoretical risk of congenital rubella syndrome if she conceives. But if she doesn't listen to you and she conceives within a month of the vaccine, what should you do? Tell her it's okay, continue the pregnancy, because it is a theoretical risk. It may not actually really happen. But if she has the rubella infection during pregnancy, then you will definitely tell her to get an MTP done, because there's a 90% risk of the baby getting infected. Okay. Now coming to the how to write the obstetric history. So this is a point where a lot of people get confused. The most common formula is the one where we use G, the abbreviations GPAL. Okay, what is G? G is gravida. Gravida का मतलब क्या है? The total number. नहीं, if you can use my phone, बच्चा. Is that okay?
Okay.
You can sit there and use my phone. Okay, so gravida is the total number of pregnancies including, the problem is now they're having holidays. Otherwise, usually he would have slept by this time. The total number of pregnancies, he's in which class? He's in class 2. He knows what pregnancy is. He knows what presentation, cephalic breach, usko sab pata hai. He knows what ectopic pregnancy is. He knows what, he knows a lot of things. Total number of pregnancies, including the present pregnancy, is gravida. He doesn't assist me. No, I don't take him to a hospital, but he's otherwise very interested in the subject. Okay, so the total number of pregnancies, including the present pregnancy, is what is gravida. What does this mean? So this includes any pregnancy irrespective of the outcome. So the total number of pregnancies, including the present pregnancy, irrespective of the outcome. So you here will include everything: molar pregnancy, ectopic pregnancy, IUD, abortions, everything. Okay. Okay, sorry. So this is gravida. What is para? Para is the total number of pregnancies. And listen carefully now, the total number of pregnancies that have crossed the period of viability, okay, excluding the present pregnancy. So you're not going to include this pregnancy, but all previous pregnancies that have crossed 28 weeks of pregnancy, irrespective of the outcome. It could have been a live baby, a dead baby, but if it has crossed 28 weeks, it becomes para. Okay. Then comes abortion. Abortion means जितने भी abortions हुए, abortion का definition क्या होता है? Any fetal loss before 20 weeks of pregnancy or less than 500 grams, excluding the present pregnancy. And living means the total number of living children that she has. Now, to understand this better, let me give you a few examples. For example, I tell you that this is a patient who has come to me today. This is her 6th pregnancy, or let me make it easier first. This is her 3rd pregnancy. Okay, she's come to me today. She's a 3rd pregnancy and she has 2 children. Okay. One is 5 years old. Okay, this baby was born at term, and then she had a preterm delivery at 28 weeks, the second one, and that baby is now 2 years old. So what is her parity index? G3, P2, L2. I was reading a message. Somebody said they were tired after 36 hours of internship. उसके बाद मैं पढ़ नहीं पाई हूँ. So sorry for that. G3, P2, L2 will be her parity index. Clear? Now suppose another scenario. Suppose I say this is her 3rd pregnancy. Okay. She has 2 children. Or so her first pregnancy was a twin pregnancy. She delivered at 28 weeks, preterm twin delivery, and both children are alive. Then she had one abortion. Okay. And this was at 12 weeks of pregnancy, and now this is her 3rd pregnancy. She is gravida 3, correct? Para 1, not para 2. Who wrote para 2? Jigar, Himanshu, no. See, this is where the NEET PG people catch you. They always ask twin. Twin pregnancy was 1. So she's para 1, but she has living 2 children from that one pregnancy, and she's abortion 1. Okay, so she's P1. Any twin pregnancy will be counted as para 1, not para 2. So she's G3, para 1, living 2, abortion 1. Okay, clear? One more example. The other example is, suppose she comes to, this is her 4th pregnancy. Okay. The first pregnancy, she had one girl. LSCS was done at 37 weeks. Okay. And that baby is fine, alive. Then she conceived and she had an MTP at 8 weeks because of twin pregnancy. She conceived twins. She didn't want to carry twins. So she had an MTP at 8 weeks. Then she had conceived again and she had a spontaneous abortion at 10 weeks of pregnancy. And now this is her 4th pregnancy. What is she? She's gravida 4. Okay. Then para 1, correct, live 1, and abortion 2, correct. So both the MTP, even if it was twins, it will be counted as one abortion, and this abortion, both are abortion 2. Okay. So Karthik, I told you, वो ऐसे question नहीं देंगे. So for all practical purposes, consider the period of viability after 24 weeks. Okay. Because we are in a country where many places will be now taking 24 weeks, or even you can take 28 weeks. And less than 20 weeks is an abortion. So 20 to 24 weeks को कहाँ डालना है is a big confusion. This has to be individualized in every situation. Even now when a patient comes to me, so many times we have 22-week patient coming and aborting. तो उसको कहाँ रखोगे? उसको abortion में डालोगे या उसको very early preterm में डालोगे? Extreme preterm. So it depends. Suppose that baby was born alive and say suppose it was 600, 700 grams, and suppose the NICU team tried their best to resuscitate that baby, then I will put it under preterm. But suppose that baby was born, it came out dead, you took the weight, it was 300, 400 grams, then I will put it as an abortion. So it's a gray area. कहाँ डालोगे उसको? Nobody knows. It has, every case has to be individualized. Okay. 35 weeks is not term, but 37 plus weeks is term. If she had abortion like this, then it is abortion 1. If it was for twin pregnancy, the pregnancy was 1, the abortion is 1. Okay. So for twins, yes, G1, P1, A1, but L2 हो सकता है. ठीक है? Correct, Aryan. Okay, so this is what you should know in parity index. Also, there are some other abbreviations जो standard नहीं है but Indians use करते हैं. One is SB. SB अगर आपको दिखता है, it means stillbirth. NND is neonatal death. ठीक है, so sometimes you will come across this. E for ectopic, M for molar. Okay, so if I give you a question, say the patient is this is her 3rd pregnancy. Okay, the first pregnancy she had a stillbirth at 7 months of amenorrhea. Okay, her second pregnancy she had a full term birth, but the baby died on the 7th day. So neonatal death on the 7th day. And this is her 3rd pregnancy. She is currently 12 weeks pregnant. So she's gravida 3, then para 2, living 0, stillbirth 1, NND 1. ये standard abbreviations नहीं है, but we use them very, very commonly in practice. Even I've seen in the last NEET PG also, they had mentioned in one question NND, and then somebody asked me, ma'am, ये NND क्या होता है? So we sometimes use them, although they are not standard abbreviations. जगदीश, इंडिया में कुछ नहीं है. इंडिया में अगर आप बहुत अच्छे सेटअप में काम कर रहे हो तो 24 वीक्स है. अगर आप किसी डिस्ट्रिक्ट हॉस्पिटल, रूरल हॉस्पिटल में काम कर रहे हो तो 24 वीक्स है. इंडिया में कोई स्टैंडर्ड डेफिनेशन नहीं है. द इंडियन एकेडमी ऑफ पीडियाट्रिक्स also says that there is no definition. It is all a gray area. ठीक है? Okay, shall we continue? Now coming to a little bit more further. Now, whenever we have a patient who comes to us and she's pregnant, we always ask her the last menstrual period. Okay? Yes, twin will be para 1. Okay? LMP, we always take how P2 because she had a stillbirth at 7 months and then she had a neonatal death on the 7th day. She had two para babies, na stillbirth था 7 months. 7 months is above 28 weeks. ठीक है? Okay. Twin pregnancy abortion will also be A1. Correct. Twin pregnancy abortion will be A1. Period of viability 28 weeks. What if 28 weeks or 24 weeks? You can take for all practical purposes 28, but in many good centers 24 भी consider कर सकते हो. Class till I finish this topic. Okay. LMP क्या है? LMP, whenever we talk about LMP, we always take the first day of the last menstrual period. So many patients will tell the last day कि वो कब उनने कब hair wash किया था. That is the last day. So always reconfirm कि when is the first day of the last menstrual period. ठीक है? Anantvir, correct. I forgot this. So there's another, so in the US, they use this wala formula, TPAL. TPL. G is the gravida, kaun number of gravida, which number of pregnancy, and T stands for term pregnancy, P stands for preterm pregnancy, A stands for abortions, and L stands for living issues. So TPAL, term preterm, उसमें preterm नहीं था. So term preterm AL. So remember TPAL in this order is what the Americans write the obstetric formula as. अभी तक एम्स में एक बार पूछा था ये, I think 2018 में, this formula. I told you ना, एम्स people like Williams. But otherwise it's never been asked. NEET PG asks our India wala, that is the G जो मैंने अभी पढ़ाया है. ठीक है? Now coming to how to calculate the estimated date of delivery. Now estimated date of delivery is calculated by Nagel's formula. Okay, and Nagel's formula says that to the LMP, to the first day of the last menstrual period, you have to add 9 months plus 7 days. ठीक है? Actually, Nagel, what he did was he described the formula as to the last menstrual period, subtract 3 months and add 7 days. Okay, but you can also do the opposite, that is add 9 months and add 7 days. What does this mean? Again, a few examples. Suppose a patient comes and she says, my LMP was on 2nd February 2024. So when is her EDD? Correct. Good, Aditya. Very quick. So 9th November. How did he do that? You just subtract 3 months. So February se वापस आओ, January, December, November, and add 7 days. So 9th November. Or simply add 9 months. March, April, May, June, July, August, September, October, November. So it's easy. Problem कब आता है? जब मैं बोलूंगी, suppose the patient says her LMP was on 30th March 2024. Now tell me her EDD. Her EDD will be now on. So let's subtract 3 months. Go back. You will have February. Okay, then January, then December. So 30th December, go add 7 days. So now you will have 31st and then 6th. So 6th January will be her estimated date of delivery, or otherwise also just go forward. April, May, June, July, August, September, October, November, December 30th पहुंच गए, फिर 7 days add करो. So you have 6th January 2025. So this is how you calculate the EDD. It's very easier. Leap year देंगे तो leap year में कुछ नहीं होगा. February, just have to see February 2024 was a leap year. So you just add that, and that will apply only if the date is coming towards the end of February. Otherwise, it doesn't matter. है ना? So don't overthink. इतना ना examiner नहीं सोच रहा जितना आप लोग सोच रहे हो. Examiner बहुत straightforward सोच रहा है अपने mind में. He or she is not trying to twist the questions. We tend to try to, I mean, you as students tend to try to twist the question. ठीक है? Just a second, hold on.